I'd like to thank the moderators for the opportunity to give this presentation. As was said, I would be presenting on baseline symptom scale scores, predict early readmissions after minimally invasive foregut surgery. We have no disclosures. Early postoperative hospital utilization, both in terms of readmissions and ED visits, are an important quality metric, both in terms of improving patient care as well as reducing unnecessary hospital resource utilization. To this point, a number of studies have shown that a large portion of early postoperative visits may be non-urgent in nature and characterized by a course of symptom relief and patient education. As such, identifying risks associated with these increased non-urgent visits are of critical importance. Unfortunately, the literature on early postoperative visits following foregut surgery is sparse compared to other subspecialties, and furthermore, most studies that focus on this discuss urgent complications and urgent readmissions. However, patients undergoing elective foregut procedures may be uniquely at risk for these non-urgent visits. Firstly, the adaptation to postoperative changes may be difficult in terms of dysphagia, nausea and vomiting, and PO tolerance. And secondly, there's a risk of misattributing those normal postoperative symptoms to acute etiologies such as cardiac and pulmonary complaints. As such, the primary objective of this study was to characterize 90-day hospital use in terms of ED visits and readmissions after minimally invasive foregut surgery, specifically by stratifying these visits by urgency, and then determining independent predictors of both urgent and non-urgent hospital visits. To do this, we conducted a retrospective review of all patients who underwent primary laparoscopic paraesophageal hernia repair and Nissen fundoplication at a single institution. We excluded redo operations and emergent cases. We looked at all 90-day hospital visits, including ED visits and readmissions, and stratified non-urgent hospital visits, which met inclusion criteria if patients were hemodynamically stable on presentation and only received symptom relief during the hospitalization. All other surgical hospital visits were deemed urgent in nature, and these were subsequently compared to a control group of patients who exhibited no 90-day hospital visits, and compared in terms of demographics, baseline comorbidities, objective workup, disease-specific symptom and quality of life scores, as well as postoperative course. Associations that were found on univariate analyses with these outcomes were then put into a multiple logistic regression in order to model predictors of urgent and non-urgent hospital visits. In total, we had 58 or 10.5% of our cohort that had a 90-day hospital visit, of which 11 or 20% were ED visits, and the remaining 80% were readmissions. And the median time from discharge was 7 days. The most common reasons for these 90-day hospital visits included dysphagia and PO tolerance, which accounted for the majority of patients, followed by pneumonia and respiratory insufficiency, as well as intrathoracic complications, which excluded leaks and included postoperative pneumothoraces and hematomas. When we stratified our visits by urgency, we found that 52% of our overall total 90-day hospital visits were non-urgent in nature, accounting for 5.7% of the overall cohort compared to 5.3% urgent hospital visit rate overall. Secondly, our non-urgent hospital visits were associated with a significantly reduced rehospitalization length of stay, which does suggest that these visits may be targets or modifiable. When we looked at baseline characteristics of our non-urgent hospital visits compared to our control, we found that these patients were younger, they presented with a significantly reduced baseline BMI, and were more likely to have a lower ASA score. In contrast, our urgent hospital visits were more likely to be older than our control group and trended towards being more likely to have a high ASA score and towards having more Medicare or Medicaid insurance. In terms of baseline workup, our non-urgent hospital visits presented with significantly increased gastroesophageal reflux symptom scale scores, as well as poorer quality of life scores regarding dysphagia, and trended towards poor overall quality of life for disease-specific or gastroesophageal reflux disease. And in terms of motility, we're more likely to present with reduced lower esophageal sphincter pressures and trended towards reduced peristalsis. In contrast, our urgent visits did not demonstrate any difference in objective or self-reported symptoms. In terms of hospital characteristics, our non-urgent hospital visits were significantly associated with Nissen fundoplications and trended towards overall increased hospital complications, but more specifically, increased postoperative dysphagia. In contrast, our urgent hospital visits were significantly increased with paraesophageal hernia repair, as well as a higher index hospital length of stay, and significantly more perioperative complications, and specifically urgent complications. When modeling independent predictors of 90-day hospital visits, having a lower ASA score, increasing gastroesophageal reflux symptom scale score, and a lower baseline peristalsis were all independently predictive of non-urgent hospital visits, while increasing BMI was protective, even when we adjusted for these confounders. In 90-day urgent hospital visits, the only independent predictor was experiencing an urgent complication during the index hospitalization, even when adjusting for age, surgery type, ASA score, and hospital length of stay. Finally, we wanted to characterize the frequency of non-urgent hospital visits by timing from day of discharge. And in doing so, we noted 3 specific spikes or clusters of non-urgent hospital visits on post-discharge day 1, 5, and between 7 to 14, which ultimately may suggest that any intervention to reduce these visits could be potentially timed prior to these spikes. In summary, we found that half of our 90-day hospital visits were non-urgent in nature. We found that non-urgent hospital visits were associated with younger patients with less comorbidities and who had more baseline dysmotility and dysphagia. In contrast, our urgent hospital visits were associated with older age and more comorbidities and increased overall and urgent postoperative hospital complications. The study is limited by its retrospective nature and the fact that it's a single institution experience, which obviously limits its cohort size. And then thirdly, the use of symptom scale and quality of life scores, which are routine at our institution, may not be at other centers, and therefore limits the predictive use of these scores. In conclusion, our non-urgent hospital visits were not associated with typical medical predictors of postoperative hospital use, and in fact, preoperative dysmotility may help stratify patients at risk of these non-urgent visits. And secondly, stratification by urgency revealed 2 distinct patient populations, which has an important ramification when looking at targeting these non-urgent visits and may represent a new paradigm in how we evaluate postoperative hospital use. Finally, patterns of non-urgent hospital visits will provide a platform for future institutional quality initiatives, specifically in terms of implementing post-discharge phone calls based on the frequency that we elucidated, as well as potentially improving our ED protocols to reduce the rate of readmission versus ED visits following minimally invasive foregut surgery. Thank you.